get started. So this is a super basic slide. What is Parkinson? I'm going to assume people in this room are at very different levels. And so some of this content will be too basic for you, and some of it may be a little more than you're used to. But this is what I think most people visualize Parkinson's as. Stiffness, slowness, shaking, slipping. Slipping is just imbalance. It just sounds better to have alliteration than Parkinson's. This degenerative, that means a part of the brain gets smaller, and right now we don't have a cure. We're working on it really hard. Very different from some of our other neurodegenerative conditions. Parkinson's is treatable, very treatable. And that's a great thing. It means that we can do a lot to maintain that quality of life to folks who suffer from this condition, particularly at the inception when people don't know what's going on and have a sneaky, increasing debility that kind of creeps up on them. And that's unfortunately a common story in folks with this condition. I really like this picture. It's a paper by Dr. Oker, who's a mentor of mine. I'm going to try and use this mouse because I think there's a second screen over there. This is the part of the picture I like. This is a young lady in shape, and she has Parkinson's, and the circle's on her foot because it's turning in. That's called foot dystonia. And this is where we're going to start talking about myths. If you look on TV at what Parkinson's is, it's maybe this middle-aged guy with the shaking hand. That's what this is supposed to be shaking. And maybe it's this older gentleman who's got kind of a stooped-over walk. It's rarely the young lady with a turning in foot. But all of these are Parkinson's disease. And it's important to note the representation of this disease is fairly diverse, more diverse than they'd have you believe. So here's the first myth. Parkinson's disease is one disease. Okay, this is some of the stuff you've probably seen if you spent some time looking about this. So there's this bad guy protein, alpha-synuclein, and it's not always a bad guy. All of us have this protein. It's doing something to help our cells. And we don't really know, people will tell you they know, but we don't really know exactly how and why this causes Parkinson's disease. We know it starts as one protein, that's what this picture is. And then it folds wrong. All protein folds to have its function. It folds wrong and it clumps up, and it clumps up, and it clumps up. And we know the cells, the nerve cells, the neurons that have these clumps die, and we lose those brain cells. And if you ask a pathologist what is Parkinson's disease, someone who works in a lab looking at autopsy slides, this is what they'll tell you Parkinson's disease is, okay? And I think a theme of this talk is going to be, if you've met one person with Parkinson's disease, you've met one person with Parkinson's disease. They all have different symptoms, different progressions, okay? So here is a typical science slide, okay? And I will not have too many of these, 2 or 3 at tops, okay? So this is from a really good paper by Dr. McCall from 2015, and it's a little dense. But the thing I want you to see is that most people, when they conceptualize Parkinson's disease, they think about genetics. This is the double helix that we've all probably seen before. And this is called the exposome. There's lots of little tiny pictures you can't see, but this one's like radiation, and this one's sunlight, and this one's being in the mountain, and this one's drinking wine, this one's smoking cigarettes. It's all the different things that have nothing to do with the stuff you're born with, your genes, but contribute to eventually developing this problem. And when people get diagnosed with Parkinson's, it is overwhelmingly common that they will say, why did this happen to me? You know, and there are some instances where the question's answerable, okay? If you have Parkinson's disease and you got it young, and you were in Vietnam and had exposure to Agent Orange, that's probably a big part of the reason why. For other guys in your platoon or your set of folks who also had that exposure may not have got Parkinson's disease. That's someone who has more of this exposome and less of this genetic. They have enough, right? If you have an alpha-synuclein mutation, a mutation in the gene that makes that protein we talked about, you're going to get Parkinson's, because almost 100% penetrant. But most genes sort of cause Parkinson's, right? I've got this gene, and 3 people in my family have this, but there's 25 of us. And you're telling me it's genetic, why do all of us have that? And they have more of this genetic component, but there's something about their exposures that contribute to their Parkinson's disease. And even though if you go to the doctor, they'll diagnose both of those people with Parkinson's disease, what's happening probably isn't the same. And my favorite example that makes this clear, it's a little scientific, but we're going to try and talk about it. So the most common gene that causes Parkinson's is this gene called LRRK2, leucine-rich related kinase 2, LRRK2, okay? And LRRK2 causes classic appearing Parkinson's disease. It happens usually in your 60s, usually has a little bit of tremor, has a fairly slow progression, nothing unusual about this type of Parkinson's disease, besides that it runs in families, and it's not 100% penetrant. So we would think this would be a good model. In fact, we're working on studies to target this as a gene, as a therapy in the future, right, as a drug target. But if you take a bunch of people, and this is from the Dr. Collier study in 2015, and I know it's small. So when you get those clumps of synuclein, those are called Lewy bodies, right? And when you take someone's brain who has Parkinson's and look at it under a microscope, they all have Lewy bodies. They took a bunch of people with LARC2, and the cardinal features, the slowness, shaking, and slipping. So bradykinesia is just Latin for slowness, special kind of slowness. Rigidity is a special term for specific kind of stiffness. Tremor is the shaking. Postural stability is the slipping. You can kind of see that these are very high percentages, 100%, 100%, 100%, 100%. All these cases had Parkinson's disease in life. They responded to medicine, but half the people didn't have any Lewy bodies. So in life, right, these people had Parkinson's disease. But if you ask the pathologist if they had Parkinson's disease, they would unequivocally tell you, no, this person didn't have Parkinson's disease. They don't have Lewy bodies made of alpha-synuclein in their neurons. So Parkinson's disease is heterogeneous. It's not just heterogeneous like I look at one patient, they're different from another. It's heterogeneous on a chemical, cellular, genetic, and biological level. Okay, that's the first one. So the fact is, Parkinson's disease is a clinical syndrome. It gets more fun up here, guys, okay? So if you have 2 of the 4 of those things I talked about, a neurologist sees them in the right kind. So there's some other kinds of stiffness, there's some other kinds of slowness. But if someone who knows what they're doing says you have 2 of those 4 symptoms, and those symptoms improve, as documented by a neurologist, with levodopa therapy, and you don't have a very clear other reason for these findings, that's Parkinson's disease. It's this thing called the NDS diagnostic criteria, 2017. And that's a syndrome, right? It's not a biologically defined process. If you don't meet these criteria, right now at least, you don't have the clinically defined syndrome, Parkinson's disease. So that's the fact. It's a clinical syndrome, not a single disease, and that has no implications for how we take care of you. And it's good to educate yourself. There is a growing movement among the cancer people. There's a big meeting in September in Philadelphia where we're going to talk about biological definitions of Parkinson's, things like taking spinal fluid or running through special machines to get more clear biological definitions. And the hope is that as we make progress on the question of different people's specific Parkinson's disease, that will allow us to make progress on how to prevent and cure this disease. Because you can imagine if 2 people don't have the same protein in their brain, giving an antibody that binds that protein might be effective for one and not for another, which is, if you guys know about, there's a therapy that was developed that did not, unfortunately, slow down disease back in 2022. A lot of people were confused by that, but some of us were less confused by that. And so it's important to kind of address these things. All right, so here's the pearl. So each of these is going to have some myths, some facts, and then the stuff you actually need to know when you get lost in my droning voice, okay? So, you're not the same as the person next to you. Having a community in Parkinson's is critical, but consistently people in the early stages of the disease go to these support groups and see someone next to them who can't speak in an intelligible manner, and someone next to them who cannot move on their own. And what they end up leading with is fear instead of inspiration. And that's why it's so important to understand what works for you might not be the same as what works for them. The side effects you get from the medicine, you can talk to some identical twins who have different side effects, right? So, you know, it's very different person to person, and progression will be different, okay? The best predictor for progression of Parkinson's disease in an individual is that individual's prior progression, not anyone else, okay? Because it's so heterogeneous. So, this is the value of having a physician who knows what they're doing, because they've seen a lot of different people with Parkinson's disease. I have patients who are 35-year-old women with Parkinson's, and I have patients who are 95-year-old men with Parkinson's, and everything in between, and that allows me to have some perspective. But hopefully, your doctor does not have Parkinson's disease. That gives them a lack of perspective. I have never had to live with those symptoms, and that means I can't have some insights that people in this room can have, and so both things are important. Okay, those are the takeaways there. Let's talk about symptoms. All right, so the motor symptoms of Parkinson's disease, the common myth, and maybe you guys already know this, is that Parkinson's disease is a disease of tremor, okay? That's not true. Parkinson's disease can cause tremor, but it is not requisite for diagnosis of Parkinson's disease, nor in most studies is it in the top 3 things that causes disability. Now, there are definitely people who tremor is the most disabling part of the Parkinson's disease, okay? But the cardinal feature, the fact is, the feature that defines Parkinson's disease is bradykinesia, which is just Latin brady, slow kinesia, movement for slow movement. And that causes a pretty sneaky motor disability. Most people don't go to the doctor because they can't use a screwdriver as well anymore. But that's a really common presentation of Parkinson's disease. Is, man, I can't use my hand. It's not fluent, it's disfluent, right? And if you go to a general neurologist or internist for that. Man, that's a broad differential. Do you have carpal tunnel syndrome? Do you have a neuromuscular disorder? Right, so it's challenging. It's important to realize this is disability to ability. And unfortunately, the overlap of people who have osteoarthritis and also Parkinson's disease is like almost 100%, right? So that means that you need someone to solve define what radiation is for you, not just slow movement, but the actual features, which is beyond the scope of this talk, unfortunately. And also understand that sometimes when your physician says, hey, let's try medicine to treat this, it might be for something that you're not noticing, but you will notice when it's gone, because it's built up on you slowly over many, many years. It's also why it's really hard to get someone's onset of disease by talking to them. Because most people do notice, or their loved one notices a tremor, but that might not have been the first symptom. Okay, tremor is the most refractory cardinal symptom. I talked about how levodopa responsiveness is part of the diagnostic criteria. 30-ish% of people don't respond to a picture tremor, doesn't mean medicine's not working. Okay. Finally, and perhaps most importantly in terms of motor symptom myths, is that Parkinson's disease symptoms are consistent. I fell into this trap all the time in residency. I'd go examine a patient, and I'd say, this person has clear Parkinson's. And the patient would come back in 3 months and see a different attending physician under my care and have a very different examination, and I would be frustrated. Am I just bad at this neurology thing? What's going on here? And the reason is because Parkinson's disease is one of the most fickle diseases. It can be bad 1 hour and not bad the next hour. If you get into traffic on your way to your doctor's appointment, your tremor score may be higher than if you didn't get into traffic on the way to that appointment. And you will make yourself crazy looking for, man, why was this day worse? Why was this day better? You gotta look at your symptoms in weeks and days, not hours, okay? Because it is part of the condition that is inconsistent. I'm gonna make a slight deviation to some neuroscience here. I'll try to keep it brief. I really like neuroscience. So the basal ganglia is this deep part of the brain where a lot of the changes from Parkinson's happen. A lot of them happen because dopamine isn't getting there when it should. Dopamine kind of greases the wheels for the basal ganglia to do what they're supposed to do. But it kind of almost works like the clutch in a, an old school, manual shifting vehicle. It's the go, no-go button. If you can picture like a fox chasing a rabbit, there has to be some means for the fox to say, maybe we don't chase that rabbit. I'm going to use more energy than I'm going to get by eating the fox. And then another situation would say, oh, it's right there, I'm going to go for it. That part of the brain, that deep, evolutionarily conserved structure, is part of what's affected in Parkinson's. So some of the problems with Parkinson's arise from that clutch sticking. People talk about freezing of gait, you try and walk and you get stuck. People talk about bradykinesia, slowness of movement, which is defined by decrement. You can't repeat this movement. The first 2 you might be perfect, but that's why we make you do it 10 times, or your doctor should, that scale says, right? Because it's decrementing over time, because that go, no-go button gets stuck. Sometimes by adding back dopamine, we can re-grease those wheels, but it's kind of important to understand from whence this comes in the brain, because it will help you have insight into your symptoms that, frankly, your physician cannot gain. You're here thinking about this stuff. This gives you an opportunity to be at home thinking about this stuff and trying to understand, make some of it better for you. I think my mic's cutting out. My voice is pretty loud. If you miss something, you can blame me for talking too fast. So I want to illustrate this point about the inconsistency of symptoms. I don't know if you guys have heard of paradoxical kinesia, but it's like a super duper interesting part of Parkinson's disease that is not myth, it's fact. So paradoxical kinesia Parkinson's disease, and in that unique phenomenon, a person with Parkinson's disease suddenly regains their ability to do things they could not do for many years. The most famous example of this is, can you guys hear me?
Something's wrong. Should we switch the mic out?
There's one right here. Can I try to switch it over here? Let's try. Maybe. All right, let's give that one a try. I'm never told I'm not loud enough, so it's a very strange circumstance for me. In any event, so paradoxical kinesia, this is a symptom. We like Latin in medicine, I don't know why. Where a significant stressor, which affects a different part of the brain than this basal ganglia I was talking about, overrides that go-no-go button. It underlines this concept I'm talking about, where your clutch gets stuck. So there's reports all over the world, all nationalities having this happen. People who have Parkinson's stuck in a hospital for, there's this famous hospital in Paris had a lot of Parkinson's patients in it back in the 1800s, before we had levodopa. And before we had levodopa, people who had Parkinson's 10, 15, 20 years on would sit in the hospital completely unable to move, because they would be frozen. Because there was no grease left to that motor, and that go, no-go button was stuck in no-go. And, war hit that area, earthquake hits that area. In the case of this particular story, in 1800s, France was a fire. And there's well-documented reports of people with Parkinson's who had not moved in 3 years, getting up and saving nurses who didn't have Parkinson's, and bringing them outside, and then after they got outside, have Parkinson's again. And that's because the adrenergic system, this system that goes fight or flight, this system can sometimes override some of the Parkinson's system. Now, we haven't figured out how to leverage this as a pill, I wish. But it's important to understand that this pathology is real, it's reported. These papers I have on the screen are all across the world, different places. An earthquake happens, and these Parkinson's patients get up out of the hospital. There's a war nearby, and the hospital gets hit with a bomb, and the patients with Parkinson's are able to leave. Not everyone has this phenomenon. The famous illustration in the movie Awakenings with Robin Williams, which is about the advent of levodopa, and he throws a baseball, the lady who's frozen, and she kind of lifts her hand and catches the baseball. I would not try that one. Not very reliable, kind of made for Hollywood, but the phenomenon is real, and it just underlines how inconsistent, eternally inconsistent this disease is. Okay, so let's talk about non-motor symptoms. So here's the myths. I've never had depression before. I'm 70. What I'm feeling through this slowness is not depression. Right? There's nothing I can do about this, so why do I care? I have a bad tremor, it's embarrassing me. If I got rid of that, I would not feel depressed or anxious anymore. These are myths because the part of the brain responsible for depression is usually the part that makes these two neurotransmitters, serotonin and norepinephrine. And both of these areas are known to be affected, degeneratively affected in Parkinson's disease. Not everyone has that problem, the same way not everyone has problems with hallucinations, or problems with thinking, or problems with walking. It's a very heterogeneous disease. But if you have this problem, it's a chemical imbalance often in people with Parkinson's, and there's a huge reticence or hesitancy to treat these symptoms. But the fact is that depression and anxiety are the #1 drivers of quality of life in Parkinson's disease. If you study this and look at what correlates with a bunch of fancy math, that's what's causing people to have worse quality of life. But man, is it common for you to see a patient and say, hey, maybe we should try treating this, and they say, I don't have depression. Well, when your movement's slow, you're not eating as much, you're not as interested in your hobbies, and you're afraid you can eat good, it's well controlled under levodopa. There's something else going on here, and just because you haven't had it before, this is part of this disease. I wish it weren't. Not a fun part of the disease, but that doesn't mean we can't do anything about it, okay? So understanding the fact is that PD can be a direct cause of these changes, that these are treatable changes. Not always treatable, it's hard. It's not easy to get rid of these things, but there are multiple modalities, multiple lines of therapy, multiple things we can do, instead of just saying, man, now I just don't like to go golfing anymore, and that's how it is forever. Now, that's not, in my view, an acceptable quality of life, but it's something we can do something about. Okay, so the myth is, I never had it before, this symptom that I'm having is it from my Parkinson's. The fact is, at least ask us. I'll tell you what it is or isn't. There are plenty of things that aren't Parkinson's. Treat your Parkinson's won't fix your arthritis, or if you're a man and you're over 60, that's part of the deal, that's not Parkinson's. The pearls are, treat the non-motor symptoms, they're important. Motor disability can be sneaky, so trust your physician as long as they know what they're doing. And if at first you don't succeed, try again. I'm really killing with the cliches this morning, I think you've noticed. All right, let's talk about some more myths. So this slide I call, we can cure your Parkinson's, just give us your money. Or that one trick doctors don't want you to know. I always want to know, for what it's worth. Any trick you have, I want to use it. I'm going to show you a cool one, actually, in a little bit. But this is worth doing because people, especially this audience, folks who are sitting in a room on a Saturday morning to learn more about how to get better, are the same folks who are going to do everything they can to slow down the progression of their disease and everything they can to feel better. And that's a vulnerable population. I mean, it's impossible. 14 years of training, you said I did after I finished, something like that, right? And still I have to read papers every day. So it's not your job to know exactly what's real and what's not. That's part of my job. But basic education goes a long way. I know it's not easy to get in touch with your doctor sometimes, okay? So let's talk about it. This is my favorite and least favorite, stem cells. I don't know if anyone has had this. If you have, I'm sorry for what I'm about to say, unless you were part of the 2 actual studies from the NIH and from Parkinson. So, So, the myth is that getting stem cells from your blood, having them injected, can cure or slow down Parkinson's disease. This is unequivocally false. Okay? This is not true. Stem cell therapy cannot help with Parkinson's disease the way it's delivered in the clinic down the street or in Mexico. Okay? And you can get it, and you can pay several $1,000s, and I have many patients who do, and many patients who report they're better because of a very complicated brain cell process called the placebo effect. But I don't think you should do that. And I'm sorry if I upset anyone. And if it helps you, I'm happy for you, but there's no science to support this. And there is really strong science to support that stem cell therapy at large can help Parkinson's disease. It's just so complex to understand that people take advantage. So when you go to the clinic that offers stem cell for your joints or whatever it is, they take your blood out of your vein, they spin it down, they identify already differentiated stem cells, okay? And then they put those back to wherever they need them and say, this will fix it, which doesn't make a whole lot of biological sense. There was a study done for one really, really wealthy individual in New York who got them to do it the real way, which is you pull out blood, you do a bunch of experiments in the lab with a bunch of chemicals to turn those back into a special type of stem cell called an induced pluripotent stem cell, an allogenic one, or something else, right? Or an autogenic one came from you. Then they turn that into a dopamine neuron that your body recognizes as your own. Then they do brain surgery. They drill a hole in your brain and they insert themselves in that part of your brain, and that does actually make a really big difference for Parkinson's symptoms. Unfortunately, the first trial caused intractable side effects that killed a couple people. So I wouldn't recommend just going and doing it on your own. But this results in a lot of studies that are out there that says this can help symptoms, because it can, but that's a very different thing than me putting it in your bloodstream, right? And it's important to understand there's a difference. There's 2 active trials for stem cells that are doing this better. One's from Blue Rock, one's from Aspen Neurosciences. They are real trials, really for brain surgery with stem cells. And we don't know yet. They report early data that's, maybe looking good, and maybe stuff we can't talk about yet, stuff that we talk about at the university. But this is something we're looking at. It's something that's exciting, but there's real risk. It's brain surgery, and it's not anything that's happening down the street or in some other country. So, and it's really, really, really expensive. Okay, I'll get off my high horse on that one. So, hyperbaric oxygen, that's my next one. A lot of people really like this, and it charges by session. This one, unlike peripheral stem cells, actually has a real mechanism, meaning there's a way you can explain it to someone to sound like it would work. We know that brain cells that die get stressed. We know that cells that get stressed need more energy. We know the part that produces energy likes oxygen, and so give them more oxygen, maybe they'll get less stressed. If they're less stressed, maybe the cells will die less. Unfortunately, we have tested this, and it doesn't work that way. We've tested a lot of things that work this way. There's a study that used gold nanoparticles to do the same thing, to support the electron transport chain. Glutathione, CoQ10 are popular supplements for mitochondrial diseases, some of which do cause Parkinsonism, not Parkinson's disease. And for those conditions, some of this stuff can be reasonable. That makes it pretty confusing when you have Parkinson's disease and you just want to get better and not let the disease get worse. But I wouldn't spend my money here. There's a big caveat here. If you're doing something and it makes you feel better, even if that's the placebo effect, I don't care why it makes you feel better. Lean into the thing that makes you feel better. Don't stop doing something that makes you feel better. But if you're looking at your options and how am I going to spend my limited time and energy to make myself as healthy as possible, I think there's a lot of people back in this room who can do a lot more to help you than this. Spend that hour, exercising, stretching, which is underrated. We'll talk about that a little bit later too. All right, let's get maybe even more people from fans to enemies. Let's talk about supplements. Okay, so the myth is, insert my supplement here, can cure or slow my Parkinson's. A quick Google search will find you 1,000 different things to put in insert my supplement here. I think some of the celebrities of the day are ashwagandha, curcumin, turmeric, lion's mane. I think that there's some older players here, like CoQ10 we talked about, that have a lot of, man, look how good this is, look how much it can help me. A positive attitude is very, very valuable. If taking a supplement makes you feel like you're doing something and you have a positive attitude and outlook about your disease, unequivocally that will make you feel better and do better. on assessments and all the rest. But when you test these things, and if you test them in a lab and put devices on people's fingers and see how fast they tap, and give them a supplement, and bring them back and see how fast they tap, it doesn't actually change the course of disease. So if you have a limited resource, this might not be, there isn't a supplement out there right now that definitively changes the course of progression of Parkinson's disease or relieves the symptoms, with 3 or 4 important exceptions that I'm going to talk about right now. Okay? So none of them have met the burden of proof. So none of the supplements have ever been proven. If they were, they'd get regulated by the FDA, and they would no longer be supplements that we consider medicines. You can see this for things like riboflavin and headache, okay? Riboflavin is a supplement you can buy it over the counter in a nutrition store. But your doctor can also prescribe it for your migraines because in clinical trials, it reduced migraines. That doesn't happen in any of the Parkinson's disease supplements, at least not yet, okay? So, that doesn't mean you shouldn't take any supplements. A multivitamin is important. Supporting your general health is important. Trying to prevent infection, supporting immunity. There's a lot of research out there for that. I'm not an immunologist. Talk to them if you want to know how helpful vitamin C is or how helpful echinacea is, but I'm not saying those things can't be helpful. The Parkinson's specific advice here is if you take a lot, and I mean a really good dose of levodopa, or if you have the pump, the Duopa pump that pumps levodopa directly into your intestine, there is evidence that this can induce a deficiency in B12. So you can check that in your blood. It will cause some numbness in your feet. It'll make it more likely for you to fall. It may not make your Parkinson's directly worse, but in a very real way, it increases your risk of falling. And in that case, vitamin B12 absolutely delivered as cyanocobalamin and checking for if you have certain GI issues on an individual basis makes sense and is important and is not part of what I'm saying here. Okay. The other one is probiotics for constipation. There are studies that show that constipation is better in Parkinson's with probiotics. They use different strains, so which one you buy doesn't matter that much. And I think that I have a whole algorithm of strategies for constipation, and probiotics is not first, second, third, or fourth, but it is helpful. And not to too personal, I take a probiotic. I think they're a reasonable thing to take. Most of this stuff is safe, if not effective, but make sure you bring the list to your doctor. Because there are some things. I see someone has a question. Would you mind waiting until the end? I'll make some time. The part about probiotics? Yeah, so probiotics have some evidence to make constipation better. We know that if you're constipated and you have Parkinson's, it affects how long medicine stays in your GI tract, how long it takes to move. If the medicine doesn't get to the part it needs to get to at the right time, it'll be less effective. So treating constipation is important in Parkinson's. You should be shooting for 1 bowel movement a day. And there's some evidence that you can have a better time with that with probiotics, but there's lots of products that can help in that way. The challenge is that there's also people who say that probiotics will slow down the progression of your disease. That is not settled science yet. I hope to find something, but to date, that has not been something that's proven. And that's a more nuanced discussion that I have to have offline. Otherwise, we'll kind of miss our boat here. So, probiotics, B12 people on really high dopamine, right? A multivitamin to support your general health is usually a good idea. Beyond that, the long list of supplements is challenging. There's one really big exception, and that's Mucuna. I don't know if anyone knows about Mucuna. I am not saying take Mucuna, but if you are taking Mucuna, this is an entirely different category from everything else I just saw. So much so that they got the picture on the slide. This right here is a velvet bean. That's the bean that Mucuna. That's what Mucuna is. It's a velvet bean, okay? And Mucuna does really and truly contain dopamine, the same stuff that's in your levodopa. Okay? So that really can have a very meaningful and large impact on motor symptoms because it has the same thing that's in your medicine. But there's a lot of buts. Gets into the slide. So, Mucuna is very poisonous. Very poisonous. So if you process it correctly, it's not poisonous at all. But if you take a Mucuna and eat it, you'll get real sick. Your liver doesn't like that. So you have to make sure your source it appropriately, and because this is not a medication, right? It's a supplement. It's not regulated the same way. So if you buy the same exact bottle of Mucuna from the same exact brand, 2 different months, it can have a very different strength of dopamine. Generally speaking, using the same brand month over month is advisable if you're going to do this. Some people prefer Mucuna to L-Dopa, and the reason is because it has a very small amount of dopamine. We're going to spend a little time talking about carbidopa and levodopa, because I just think it's that important. but I'm going to take a second to explain what the carbidopa and the levodopa are, because I think some people don't get that lesson, and it's important. Okay, so carbidopa does not go into the brain, never enters the brain, and exclusively cannot enter the brain or wouldn't work. Levodopa is useful anywhere in the body in the brain, but if you take it and it affects the body, it causes side effects. Okay? So the only purpose of carbidopa is to reduce the side effects of levodopa, and that's it. That's all it does. Okay? So if you have L-dopa, it's a precursor of dopamine. It turns into dopamine, that's when it has an effect. The reason we give it as L-dopa is so it doesn't turn into dopamine before it gets through the blood-brain barrier and gets to your brain. So you take the carbidopa, so the levodopa stays levodopa until it gets to your brain, and then turns into dopamine. This is important because if you get light swelling from your carbidopa, levodopa, some of the nausea, but not all of it, depending on what the nausea is coming from, like some of the common side effects are because you have incompletely blocked the enzyme that turns levodopa to dopamine in the body. Okay? This is causing changes in blood pressures that are significant, it causes changes in how it moves, it has a lot of effects. Okay? Obviously, purines does not have any carbidopa in it. So if you take carbidopa, levodopa anyway, maybe you're getting some benefit, because if you block the enzyme, you block the enzyme. Some folks do a little more, they make the carbidopa by itself, the branded name is Lodozin. It can be a pain to get, but actually can be effective if you're having symptoms or side effects of the carbidopa, levodopa that are from peripheral conversion of L-dopa, okay? But this is a really important point for Vicuna because it's like a microdose. It's a very small dose, and some of it is getting used by the body. And if you just churn up the dose, you're going to have more of those side effects. People who like Vicuna by itself are typically people who have early stage disease and mild symptoms, and even the lowest dose of carbidopa and levodopa is too strong for them. And some people use it as an adjunctive because they feel it's natural, which is valid, and everyone can have their own opinion. Understanding that what the actual supplement is doing is recapitulating or recreating the effect of the medication is really, really important. It also means you have to tell your doctor. If you're having side effects from too much dopamine, right, they're going to lower your carbidopa, levodopa, but if it's because of its unopposed levodopa from Vicuna, I might not fix your problem. And that's true of all supplements. But there's some highlight supplements that like you really want to tell them if you're taking St. John's wort, because that affects how your liver metabolizes a lot of medicines, right? So you just got to bring that list. Okay. So pearls. Be wary of your sources. Ask your doctor before you spend money. And don't listen to silly people like me if it works for you. Lean into what works, okay? Lean into what works. But seek advice from professionals. I promise we spend a lot of time learning about this stuff. Okay. Are we done with the depressive stuff? Talk about some happy stuff? I know. I think it's really important knowledge. But let's talk about taking control of your health. Or is there any good news? All right. So medication. Man, there's a lot of myths about medication. A lot. So the most common one, and this is a myth that is entertained by most physicians who didn't do a fellowship in movement disorders and were trained before the 1980s. And the reason is because the early studies on levodopa showed that people with levodopa have more dyskinesia. So a lot of people believe starting levodopa therapy, carbidopa, levodopa, or any of its cousins, Rotari, you name the cousins, CR, there's the new one, you can break it into little pieces, they're all the same medicine, right? Starting it earlier, we used to think that caused dyskinesia. It wasn't ethical because of how bad it is to not treat Parkinson's patients with this medicine to study this. So for a long time, we couldn't figure it out. Then we found a population of people with Parkinson's in a remote part of Africa who couldn't access levodopa. And we looked at rates of getting dyskinesia based on how much dopamine they were taking. Obviously, we found people we gave them levodopa to help them not be frozen. And what we found is the only consistent and reliable correlate of how much dyskinesia you had was how long you had Parkinson's disease, which is correlated with how many of those brain cells have died back. That's a different thing. So I want to take a second to clarify this, okay? Because it's important. How much levodopa you're taking today does affect how much dyskinesia you have. So if person A has had Parkinson's for 5 years, and their first ever dose of levodopa is today, and person B has had Parkinson's for 5 years, and they're taking levodopa for 5 years, if they're somehow identical, I told you no two people are, but just stick with me, those two people would have the same amount of dyskinesia with the same levodopa dose, even though one started 5 years earlier. But if you gave one 2 pills and one 1,
the one who took 2 pills has more dyskinesia at that time point, okay? So it doesn't affect the development of the side effect, right? But the degree or amount of medicine you're taking at that time point can be adjusted to account for the side effect. There's other approaches, it's a little complicated, it's never well explained in your clinic visit, so I think this is actually something you should walk away with your knowing, okay? Okay. The next myth is that starting levodopa earlier means you need more levodopa over time. Again, this is a function of loss of brain cells over time, the normal progression of disease. Taking more levodopa early does not mean you need more levodopa later. The reason to take levodopa early is because it will help you maintain function so you can work with the really smart people doing therapy to actually maintain the quality of life. That's why you take medicine early. It does not, even levodopa doesn't change how fast loss of brain cells is, okay? So there's no evidence to suggest that you need more medicine at that 5-year point. You started at 5 years than you started at 1 year. There's one exception. It's rare. It's called dopamine dysregulation syndrome. This typically happens in young men, a guy in his 50s, and it's actually addiction to dopamine. So nothing to do with Parkinson's symptoms. The Parkinson's symptoms are well treated, but they have a psychological need to take more dopamine. They'll escalate their dose. And the risk for this is higher. It's pretty rare. Your doctor should know it. If you're worried you have it, the main physical manifestation is something called punding, which is like you're always doing repetitive behavior, messing with your watch or messing with your buttons. And there are medication approaches, like borotic acid, that have some evidence. So good to talk to your doctor about, but not a reason not to start the medicine when you need. Okay, now, the other myth is if I wait to start medication, I may have more options. I don't know where this came from, but I hear it all the time. And so there are many medication options that are only safer earlier in the disease, okay? Dopamine agonists, anthedine, these are medications that are going to cause significant problems to your thinking, sleepiness, and that kind of thing if you're older. Or on the sickle of Peters list for older folks, okay? So your physician might be reticent to start those ones later on. Including myself, I'm reticent to start those because I don't want to cause that problem. So waiting to start medicine actually gives you less options, not more. It is typical for most of us who treat Parkinson's throughout the duration from early to very late disease that we will simplify your programming to people, not complicate. That's what tends to work. But it also depends on your access to advanced therapies, which is beyond the auspices of this talk, but things like surgical therapies, which I spend a lot of my time doing. Okay. Clear as mud, right? Let's keep going. I know I'm talking to you way too much about levodopa, but it is important. I want to explain this in a way that's visual. I'll be quick. Here's early Parkinson's. Here's where you take the medicine. It goes into your bloodstream. It gets into your brain here. It starts helping you. This little window is called a therapeutic window where the clinical effective benefit occurs. Then it starts to run out of your system, and you drop down below that, and you have inadequate symptom control. This is earlier in the disease. As the disease progresses, you have less neurons that can suck up and shoot out the dopamine and keep the levels regulated. So you're just bathing the cells with dopamine that you're giving, instead of letting the cells that are there control how much is being used. And so you take the medicine, it works, it rises quicker because you don't have the cells to regulate that amount. It does end up in that therapeutic window, but at the peak dose, you're sleepy. At the peak dose, you have dyskinesia. You have some complication of therapy. And it lasts a good amount of time, and then you drop down on the back half, you have some better time, and then you're off again. This is for a single dose. In advanced Parkinson's disease, you have no buffering. It's just the medicine comes in and out. And yeah, on the way in and out, you have this, 10 minutes that's good, but most of the time you're taking medicine, you're feeling worse than when you're on medicine. And that's the consequence of the disease and progression. And you want to understand that personally, and you want someone who's going to understand that for you, because it is really important for my job. So, this is what it looks like if you take the medicine, on a typical schedule. You're early to mid-disease, you're taking the medicine every 4 hours while awake. By the way, your dosing should be based on how long you're between dosing. The half-life of this medicine isn't that long. There's some buffering that we talked about from living cells. You take a dose at 7 a.m., and the curve, how much in your blood, looks like this. That's pretty good. And you're early in disease, and there's your therapeutic window. You don't feel the medicine kicking in when you take it. You don't feel it wearing off between doses. Your doctor keeps asking you, no, just take it. I'm better than I was before. This is early disease, okay? You're really popular at this part. You like your Parkinson's doctor at this point. Had disease 3 years, now I'm popular because I'm making you feel better, okay? What happens is 2 things, right? You have less buffering, So now the line is just whatever's in the bloodstream. See how that, I'll do it again. See that little blue line? It's just right on top of what's in the bloodstream, no buffering. And your therapeutic window is getting thinner. And now, look at all that time that's in that dyskinesia or side effect causing area. Okay? I know this is complicated stuff. I try not to make it too terrible, but I do think it's important. Okay, a little advice. Now you're coming to the doctor and you want them to fix this problem. And you're frustrated because when you go to the doctor with your problem, they don't actually fix your problem. And some of that, I'll take most of the blame. But some of it's on you guys, a little bit, okay? Pay attention to what symptoms you have and when you have them. Take notes for 1 week for your appointment, okay? Pay attention to when you're taking your medication. Because no one's body does this, okay? Your belly's absorbing the medicine, there's variability in how your liver clears the medicine, how your kidneys clear the medicine, there's variability in how much dopamine your brain uses when you're more active, you have more adrenaline, you chew up more dopamine faster. You go run a marathon, your dose is going to wear off faster, okay? But if you give me this information, you write down and bring to your doctor when you're taking the medicine, when you have the symptoms, then I will work with you to troubleshoot it and do something personalized for you instead of what I do for every other patient. If you don't give me any information that's specific to you, my only choice is to rely on my experience with other patients. And this is a very salient and active step you can take to take control of that. Okay, exercise and therapy. A lot of you guys are doing this because you're here. So I already told you again, I lied to you. I said there's nothing that can slow down the progression of Parkinson's disease. That's just because there's nothing I can do to slow down the progression of Parkinson's disease. There is something you guys can do, and people back there can do. There is actual evidence that exercise slows down Parkinson's disease. It's the only thing that has the evidence. A big trial where I work right now looking at this in a more detailed and nuanced manner. But the big trial that exists is something called the Parkinson's Outcomes Project. And what it says, exactly what it says, is consistent exercise means that 2 years after you get consistent exercise, your quality of life will be better, and how much you can move will be better, which I think we all want. Okay? So this is up to you guys. I'm not going to be there with you at home being like, hey, let's one more time, right? That's these guys back here. And that's really important. Nothing I'm doing is actually going to do this, okay? 2.5 hours of consistent exercise slows the rate of decline, okay? That's 30 minutes 5 times a day. And the only reason this was done this way is because the large heart studies that show exercise helps you, BC studies, use the same metric. When they say 30 minutes of exercise, they're talking, man, you have to kind of talk like this. That level of exercise, 30 minutes 5 times a day. It's 5 times a week, not 5 times a day. No, I did say it wrong. Yeah, just 30 minutes, 5 times a day. No, so the important part about this is it's not a magic number. They just picked a number and picked different groups. Any movement you're doing is good movement, okay? It's not clear if there's an upper bound. Like, is more better? And they're studying that still, more than that. But to get this benefit, to split them into groups, that's what was done in the study. So when your doctor says you should do 30 minutes of exercise 5 times a day, hard enough that you can't carry a conversation easily, they're saying it because they studied people who did that, not because it's some magical potion that's different than doing 35 minutes or 25 minutes. Do what you can do, or do something, okay? All right, now, the other myth is there's nothing that can demo freezing of gait. And the reason this is a myth is because when you come to your doctor and ask him to fix your freezing of gait, they will tell you there's nothing they can do about your freezing of gait. There are people who reliably improve their freezing of gait in the on-medicine state. So if you're having a lot of off time where those squares off, it doesn't work, and you're one of those lucky few. But most people, the changes in gait are thought to be mediated by a different receptor, not by dopamine, but by this thing called acetylcholine in the front part of the brain, as opposed to like the dopamine in kind of like the deep back part of the brain. Okay? And we don't have medicine that helps that. We even tried brain surgery and it didn't help this, okay? What does help this is physical therapy. But if you go to a physical therapist who spends all their time working with knee replacement patients, they're not going to tell you the things you need to know with how to fix this. There are very specific strategies, and this is the time to get creative. So I got like 5 minutes. So I got a friend named Dr. Chan who I trained with. This is one of his patients, okay? This was published in 2023. So this is a guy who went through therapy for freezing of gait, and I'll talk through it. So this is him trying to walk. Remember that sticking clutch metaphor? Look at this guy's feet. So that's freezing. Small stuttering steps. Now most folks who experience this going through doorways or doing turns. That's the most common place they can start. All right, and there's some good therapy techniques to help. This gentleman without a walker would fall. This is a really debilitating symptom of Parkinson's disease, and a really frustrating one to be told your doctor can't fix. Now, this visual strategy is pretty good. Putting this over the doorway of one of your doors that you get frozen in, and teaching yourself step over the line, double-sized steps, arch in place, use a tune, are helpful. But look, it didn't help him. Look what's helping him. You see what he had on his feet? That's a workout resistance band. That's it. Look how he walks. So here, I'm going to show you again. Look how he walks with nothing. Pretty rough. Look how he walks with the traditional strategies. All right? Still pretty rough. This guy is a smart guy, and he just decided, hey, I noticed if I get moving, I can keep moving. I promise you someone of his weight, that level of resistance band, did not pick up his foot. This is called external cueing. Okay? This means that something outside the body is helping grab that motor. It's not quite as exciting as a fire. We started outside the hospital, but this external cueing phenomenon is part of what we leverage in physical therapy to help increase the gait. And there are things to try. You have some smart people around. The point is, if you want to read this, it's called Elastic Priming of Gait, Jason Chan. It's a very dense. It's not a layperson paper. It's a medical paper, but it's a pretty good paper. And it's just interesting to see. There's things that we can do. And so the pearls here are, if you want to improve a symptom, write things down about the timing and how it relates to your levodopa. If you want to be mobile, move. I know it's not easy. I know it's not hard. I know you have a disease that says you can't move sometimes, but you got to try. And talk about what's bothering you. Sometimes it's okay to get creative. Okay? I'm trying to make the pearls 10,000 foot view because I know I talk about it. You guys are doing great. All right, we're almost at the end. So at the end, I just want to give some general advice. Just a couple things that I think are commonly missed. Because we're rushed in clinic, and we spend most of our time saying, how's your tremor, how's your slowness and stiffness? You can't even tell, let me examine you. All right, you're going to go up a half foot. All right, you're going to go down a half foot. Okay? But there's other things that Parkinson's causes, and we should talk about them briefly. Okay. Dry mouth, probably not your PD. Okay? Drooling, almost always is your PD. In Parkinson's, drooling is not because you're making too much saliva. That's why most drooling happens. It's because a lot of automatic functions are reduced. When I walk into a room, I've never had a patient before, I usually know if they have Parkinson's within about 10 minutes, tops. Usually quicker. And what I'm doing for part of that 10 minutes when you're telling your stories, I'm counting how many times you blink. Because people with Parkinson's don't blink as much. Because automatic functions are decreased in Parkinson's. That go, no-go button. It's not telling it to go automatically, okay? That's true for swallowing too. We're all swallowing all the time. If you don't do that, what happens to your saliva? You drool. This means very counterintuitively to other sources of drooling, where it's too much drooling. Sucking candy can actually help this, like a butterscotch. Yeah, if you have choking problems, maybe not your strategy, and that is common too. But in general, there's things we can do. There are medicines too. Old school trick is there's this atropine eye drops that are used for eye disease, and instead of putting it in your eye, you put it on your tongue a couple times a day. That reduces drooling. If that doesn't work, we can do toxin directly into the glands that cause you to salivate, and it will stop you from drooling. So we can treat this, and it's not fun. And a lot of the is this. I don't think drooling is a fun stigma to have with you. So no one would address this. It'd be empowering. How about sleep? No one sleeps well. I'm sorry. Even with Parkinson's, as we get older, sleep is hard. Our bodies ache. Our brain's physiologic need for sleep decreases. I know you disagree if you're living that life in retirement, but if you look at human brain sleep behaviors in healthy individuals, the amount of sleep you need decreases as you get older. Okay, and that makes it feel like you're waking up more than you should. But there are Parkinson's-specific problems with sleep too. Okay, if you're having trouble falling back asleep, so you wake up in the middle of the night because you have to pee because you're an older gentleman, or you wake up in the middle of the night because you take carbidopa, levodopa every 4 hours. Your last dose is 7 p.m. You go to bed at 9 or 10, and you're waking up every morning at 2 a.m. because your dose is worn off, and now you're sticking to bed, right? So you're waking up every morning at 2 a.m. consistently, and it's hard to fall back asleep. You feel a little anxious because you have a non-motor symptom that's wearing off. You can take levodopa then. It will help you fall back asleep. And people just don't ask, don't do this. I don't know why, but I don't know, 80% of the people I see for the first time who've had this disease for more than 5 years, this is helpful advice. So it's just good to know about. By the way, it works fast. faster if you chew it if you're on the IR formulation, but it tastes disgusting. So that's your call if you want to have the extra 15 minutes before you fall asleep. Some people make a slurry with water. It's also safe to do. It works. Stay stable for a day. So how about if you can't fall asleep in the first place? That's your waking up, right? You can't fall asleep in the first place. I can't tell you what to do right now because that's a very complicated question. But I can tell you I have at least 6 things that I do. I'm looking right now. But there's a lot you can do. Granted, you only have so much time with your doctors. You got to prioritize. What do I care most about? But this is something that's Parkinson's related, something that we can help with. Don't thrash around in your sleep. You can't share the bed anymore with your spouse because you accidentally punched them in the face when you were dead asleep, or you threw yourself out of the bed onto the floor. Believe it or not, Parkinson's disease, very common actually starts before the Parkinson's disease starts in many cases. This is called REM behavioral disorder. It's caused by that same alpha-synuclein protein. Some people get it and never get Parkinson's, but the conversion rate is high 70%. If you have that problem, you're eventually going to have Parkinson's. And we can treat this. People will tell you melatonin first. In my clinical experience, if it works, it's great, but not everyone. But there's other medicines you can use. Sometimes there's drawback to those medicines, but it's worth bringing this up with your doctor and knowing that it's related to Parkinson's. Finally, I don't know if someone's not told you this today, you're in that room, you're in the right room to have heard this, but stretch. Please stretch. I have to stretch. I say this so many times a day to patients that I now stretch every day because it's just silly not to, but I don't mean like anything crazy. I mean, bring your large joints through the range of motion, and there's some evidence that passive long holds 30 seconds or longer are better than like this dynamic moving thing, slow long holds, okay? Don't stretch your shoulders like this though. That's a rotator cuff, in line with the joint, okay? Just so it's been set, so you don't hurt yourself and blame me. Okay, so this is most of what I wanted to say today. I wanted to leave a little more time for questions, but I think I've got like 5 minutes. But here's some other resources. So you're going to try to learn more about myths and facts, and it's hard to know where to turn. Trust these guys. Parkinson's Foundation, I go to the Fox Foundation. If you go to UF, send your doctor a message. I know we take a couple days to answer because we get lots of messages, but we do try to help. If you're going to these resources, there's plenty of really, really good resources out there. Sounds like ReBloom has a page, probably very reasonable, but vet it, right? Bring it to someone who doesn't have skin in the game. I'm going to play in the state of Florida. It doesn't help me at all. I will tell you what's actually going to help and not going to help, and hopefully the people that are helping you are in the same place. Okay, thanks for your time and attention, guys. And if you have 2 minutes for questions, I'll take them. She makes a good point. American Parkinson's Disease Association, also a huge and important resource. I have bias on this one, because I know the people who write these documents personally, so that's the only reason they're on the screen, but again, just ask. Just ask.
We are going to open up to questions. This really fun, cute. It's a microphone.
You're just talking to it.
You have a question? Sure, go ahead.
Thank you very much for coming. We really appreciate it, and what Melanie is doing is just fabulous here. Let me ask you, you mentioned that taking multiple vitamins. How does taking multiple vitamins work, or how, particularly the B12, affect Parkinson's improvement?
So a multivitamin is a general recommendation that's kind of trying to help as many people with low-hanging fruit as possible. There are plenty of people with a nutritionally replete diet
can toss it or
who
hand
get
it
no
whatever you
benefit from multivitamin. But a well-designed multivitamin is low in what are called fat-soluble vitamins. These are A, E, D, K. And high in water-soluble vitamins. These are all the B vitamins, pantothenate, which is B5, folate, thiamine, riboflavin. And the reason for this is because you pee those ones out if you get too much of them, with the very important exception of pyridoxal phosphate, which is B6. Do not take isolated B6 in addition to your other multivitamins because that can cause neuropathy. Not Parkinson's related, but important to know. So the answer is that if you are low on any of these vitamins, they act as cofactors, which help in the production of energy in cells, as well as clotting. I mean, there's a variety of things. Vitamins are important for a lot of reasons. But if you have another deficit of any kind, Parkinson's, it's usually multiplicative. That means if you have Parkinson's and you get a urinary tract infection, all your Parkinson's symptoms get worse. If you don't sleep well at night, if you get stressed, this is a well-known phenomenon. So the reason to encourage multivitamin use is preventative to affect competing etiologies more than directly with Parkinson's, with the exception that I mentioned of B12, because we can actually cause you to be low in B12 by out-competing its absorption with frequent levodopa because they're absorbed in the same part of the intestine. For folks who have normal B12 absorption, there are more nuances than that. If you want to talk more about it, I'm happy to, with intrinsic factor, parietal cell dysfunction, things like pernicious anemia, there are caveats. Of course, there's always caveats, but largely speaking, vitamin supplementation in Parkinson's is with the goal of prevention and not with the goal of directly intervening on the pathology of Parkinson's, with the exception of the ones I mentioned. Does that make sense? And that's why for low, one a day vitamin, we call it good, is usually the strategy. There are other exceptions. The other big one that I didn't get into is that the rate of restless leg syndrome much higher in Parkinson's disease than the general population. The treatment for restless leg syndrome, you don't know, is first-line treatment should be in my opinion, gabapentin derivatives. The second-line treatment is dopamine medications, which you probably don't have to get Parkinson's for most folks. And in those cases, you have a worsening or inability to treat that condition if your ferritin is low. So that's the other thing, it's a multivitamin that you drink with iron.
Do you recommend a high dose of vitamin B12?
I only recommend a high dose of vitamin B12 if your level of B12 once checked is low, or if you have peripheral large fiber neuropathy, and you can't find a vibration or proprioception, where yourself is in space in your legs. And that's something you check. I will say the reference range for B12 in most laboratories, the lower limit is around 250 or 300. I rotate Parkinson's patients about 400 because it's preventative. And I think that avoids the problem of running into deficit. I think the gentleman over your left shoulder has a question. Oh, over here. Hi.
I have a question around mental health, and you mentioned the non-motor system symptoms, right? I'm finding this one to be particularly challenging in my family. So, a couple of things. One, what kind of suggestions do you have for support? And two, are there psychologists that are kind of more specializing in this type of mental health need? Because it seems to be very different. And I'm speaking about the patient.
Okay, so it's a huge question, and I'll give you some high-level answers stuff, but that deserves a conversation based on where you are, and obviously much more familiar with the resources locally in Gainesville, otherwise they're referred out. There's a very, very large deficit of psychologists, very large. And among psychologists, there are two very large schools of thought, and I'm going to do some, a psychologist wouldn't be happy to put them out the set, okay, frankly. So there's CBT, cognitive behavioral therapy. There's dialectic behavioral therapy, which you don't care about here, that's for personality disorders. All right, and then there's psychoanalytic psychotherapy, which is everything else, anything that involves talk therapy. Evidence base is in cognitive behavioral therapy. The reason the evidence base is in cognitive behavioral therapy is because this is standardized. It's the same in medical practices, so it's easier to show a treatment effect. It's quite possible that the other kinds of talk therapy are more effective for an individual. It's just incredibly hard to prove that in a study because you have to do it on a large number of people. It takes time to do that therapy, so you have different providers, they do it differently. Individual patients have different levels of buy-in, so it's harder to show that difference. So if you're asking about the evidence, which physicians should hopefully deal in, CBT has the best evidence, and you can look at psychologytoday.com has a list of who provides CBT. You type in CBT, you look. However, the second part of the question, Parkinson's-specific disease knowledge, is a harder part because that's down to the individual and their experience. Geriatric providers generally have a better referral base. Someone who's a geriatrician as opposed to general internist will have a greater knowledge of people who deal with psychological developments that happen later in life. Because most people who have depression and anxiety starts much earlier in life. However, the treatment itself of the depression piece, with the exception of optimizing motor symptoms and recognizing that it's a real and reasonable grief reaction to feel sad because you're diagnosed with a neurodegenerative disease, that's an okay thing to feel, and you should feel that, right? We're not trying to make you not feel. That, once you recognize that piece, the general treatment is similar, with one very important exception with medical management, which is that the rate of what's called apathy, which is not being sad, which is not caring at all about anything, no feeling. Starting an SSRI, which is the most popular class of medications for treatment of depression, in a patient with Parkinson's, is a little bit more likely to cause apathy. And if it does, you switch to an SNRI, which is like venlafaxine or duloxetine, that is venlafaxine. There are medicines that you can switch to, but that kind of nuanced knowledge, I'm fortunate where I practice that Craig Conklin is there. He's like the man for psychiatry and Parkinson's. So he knows the stuff, and I don't have to, if I refer him to him, Dr. Kumar or someone, I know that they know what they're talking about. The level of involvement of your local team is variable. I just can't comment on that. In terms of getting buy-in from the patient, it's explaining to them that there's a biological source, though it isn't really important for treatment, is important for acceptance. Because unfortunately, we have a huge cultural problem with accepting mental health. And I would love to solve that cultural problem, but it's unlikely on an individual basis with someone older in that moment I'm going to solve that cultural problem. So even if it's only a part of the story, and they did have antecedent depression, giving them something to cling on to and saying this is part of their disease process may allow them to help themselves. And that's a very challenging thing to do when you're not feeling well. When you're feeling sad, it's hard to buy and do these things. It's hard to go to these appointments and talk about this. So it's kind of like exercise. Any little bit you can do is helpful. CBT is the best evidence. Look it up graphically. Go and talk to your local team.
And would that be the same resources for hallucinations and delusions?
Absolutely not. Completely different. So hallucinations and delusions are on the spectrum of psychosis symptoms, not on the spectrum of depression and anxiety symptoms. For that, you need a psychiatrist or someone who knows a lot about neurodegenerative conditions. Fortunately, I have a lot of friends who do that. I do manage those myself in my patients frequently. That is a nuanced topic with a lot to talk about, and it's difficult because many, I would go as far as say almost all medications that treat psychotic symptoms are very bad for Parkinson's. They're on the list in the Parkinson's guide. It's like, hey, don't ever let someone give you these. Those are medications for hallucinations. And exceptions to that rule are clozapine, which is blood tests every single week forever. Okay, pretty much. I'm being facetious. It's a little less than that, but it's a very heavy burden of testing. Seroquel, which is a reasonable option, but has its own drawbacks. And then there's another medicine specific to Parkinson's called pimavanserin, but the testing of that medication is done in more mild patients. So it's a little bit of a less option. It can be prohibitive, but we use it. That's pimavanserin. Sorry, I tried to use generic name.
Okay, yeah.
Pimavanserin is a generic name for the brand name, Nuplazid.
We do have the rep here.
Yeah, and that's helpful. It's like I say, it's a very individualized thing, and that's like a, hey, ask your doctor for medical advice when it's there. But do be aware, psychosis spectrum thing, delusions, hallucination, separate and independent from, not that they can't go together, but separate and independent from depressive level symptoms, which are more likely to respond to talk therapy. You cannot typically use talk therapy to treat a delusion. It's not too successful. Though they can give you strategies for how as a family to react.
Hi. What is the difference between Parkinsonism and Parkinson's disease?
Well,
We're going to take one more question after this. Okay?
it is this one. So this part right here, 2 of the 4 of these, that's all you need for Parkinsonism. Parkinson's disease is if you meet the rest of the criteria for the syndrome. So when someone says Parkinsonism, most of my patients, the first time they them, I tell them, it's really likely you have Parkinson's disease, but what you have right now is clinical Parkinsonism. And to confirm this, you must see a response to levodopa therapy and exclude some of its cousins. In the first 3 years of disease, these things can look identical. The biggest study of this is the UK Brain Bank study, which looked at the brains of a bunch of people with what we call atypical Parkinsonism under a microscope. If you take some of the best people in the world, we're 95% I get Parkinson's right. We're in the 70s for getting PSP or MSA right. Mostly because they look like each other, it can be hard to tell them apart. And PSP and MSA are cousins of Parkinson's disease that take a different turn. But in the first 3 years particularly, there's what we call red flag symptoms that kind of have us have our feelers up. Things that haven't been able to really happen with Parkinson's, and it could still be. The challenge in this is if you do not have a clear reason part. Because most folks have some other explanation. If you have long-standing diabetes, that can cause some similar changes to MSA. So if you have long-standing diabetes and Parkinson's disease, it may be really hard for your doctor to be 100% sure. Now, if you have a very robust response to levodopa, they're going to call you Parkinson's early, but some percentage of the time, they're going to be wrong. And it's not that they did anything wrong, it's just that you have to have a levodopa response in the form of MSA, which is rare. And so Parkinsonism is a label of a clinical syndrome. Parkinson's disease is a syndrome with caveats and diagnostic criteria that allows us to put you in a bucket to kind of help predict what's going to happen next. Okay? But you can have Parkinsonism from taking some medicine as a side effect, right? But that's not a neurodegenerative change in the brain. If I'm saying you have Parkinson's disease, even though it's heterogeneous, different people, I'm also saying that it is progressive and neurodegenerative. Does that make sense? I know. It's so hard. How about this gentleman all the way back there? Just to make you walk.
I've been told this is
Come on, have fun. Toss it to him.
Vernon, you ready to catch it?
The weather this summer has been extremely hot. Does temperature, with hotter weather, does it make the disease worse? With cooler weather, does it help the disease?
It's a great question.
I'll take it.
And the answer is technically no, but in practice, yes. So I'll explain. So the actual buildup of the protein in the brain, the symptoms response to carbon levodopa, these things don't change based on weather. And that's not true of all neurological conditions. The famous example is multiple sclerosis, where temperature directly affects how the nerves are transmitting signal. It has a direct effect on disease. That's not the case of Parkinson's. However, in Parkinson's disease, and especially its cousins that we were talking about, there is a propensity to have autonomic dysfunction, which means some of the parts of the nervous system that are working all the time in the background aren't doing their job quite as well. And the most common, besides the urination thing, which is hard to tease out for the prostate issues, the most common thing that people experience there is when you stand up, your blood pressure drops. Now, if you don't have that autonomic dysfunction, that will correct, and by the time you measure it, you might not quite catch it. But the first-line treatment for this, what we call orthostatic hypotension, or blood pressure getting lower with standing, which is common in later, moderate to late-stage Parkinson's, and in Parkinson's cousins, but less common in early Parkinson's. That autonomic dysfunction is absolutely significantly worse if you don't have a sufficient solute intake. That's salt. I didn't tell you to eat salt if you have hypertension, but if you have low to middling low blood pressure, in order to keep that water you're drinking in your blood vessels, it needs solute, like salt. So salt like Gatorade that has electrolyte load, right, is important when it's hot out, especially with people with Parkinson's. Because all of us, when we stand up, the blood's got to go from pulling in the veins in our legs to our heart to get to our brain, right? And the people without Parkinson's, they stand up and the nerve cells say, squeeze those muscles and send that blood up to the heart. It takes longer in Parkinson's for those nerve cells to say, squeeze those leg muscles and bring the blood up to the heart. So if you need more movement up there because the tank is low on fuel, man, you're going to have worse symptoms. And that's going to manifest as feeling bad kind of all the time. Because you're pretty much always moving, getting up and down and things, and it will have side effects. So hydration is critical, and obviously you lose solute and liquid through sweat. So yes, if it's hot out, there are risks for things being worse, but not in the direct way. It's the case for other diseases. The cold question is more complicated. In some of Parkinson's cousins, there are issues with regulation of temperature and body parts. That's exceedingly uncommon in Parkinson's, so cold is usually a little less bothersome than some of the cousins. However, some folks don't like the way their joints feel, and there's a multiplicative factor there. So I would not go so far as to say cold is helpful, but if it helps you, then it's helpful, right? But in a larger scale, not so much.
Talking to the Jew, I guess. Okay, so it's time to get up and move. Don't sit for too long. Go visit the tables. There's some resources that came up during the talk, like Neurological for Hallucinations and Delusions. We do have the American Parkinson's Disease Association here, which can direct you to all kinds of resources to answer any question that you might have related to Parkinson's. That table is right out front. And all the other tables down the hallway, and of course, lunch. And we will reconvene back here at 1:45. So I'll round you up. Okay, so go ahead, take your time getting up, go to the bathroom, sit at the table, and please eat some food. Yes, let's applaud.